Welcome to Efficient, Effective, Excellent, Issues in Logistics and Operations in Hospital at Home, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. We'd also like to recognize the generous support of the John A. Hartford Foundation for the Users Group and for this webinar series. It's now my pleasure to introduce our moderator for today's webinar, Dr. Al Su, a member of the Hospital at Home Users Group leadership team. Dr. Su has been at the forefront of the hospital at home movement in the United States during the last decade, and today he is the director of Mount Sinai at Home and a professor and chair emeritus of the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. Dr. Su also holds an appointment at the Geriatric Research, Education, and Clinical Center at the James J. Peters Veteran Affairs Medical Center, which has its own hospital at home program. Please take it away, Dr. Su.
Thank you, John. And I'm pleased to have the opportunity to welcome all of you to our webinar today. As John indicated, it's sponsored by the Hospital at Home Users Group, a group that was founded by me and my colleagues, a number of years ago with the generous support of the John A. Hartford Foundation. It is a group, the original group is a group of organizations that had started and implemented hospital at home programs, and it has since grown to encompass, other individuals interested in hospital at home care. Our website is listed on this slide as well, on the next slide rather, is listed on the next slide, as well as, our social media tag and information about our Technical Assistance Center. Gabby shown on the previous slide, at the bottom of the previous slide, which I will tell you a little bit more about, at the end of this webinar. The users group has had the opportunity of sponsoring a number of webinars, starting with, as shown on this slide. There have been 4 webinars to date. Recordings as well as the slide decks are available on our website for you to review at some point. Today, as John indicated, we're going to be talking about logistics and operations, efficient, effective, and excellent issues in hospital at home care. The slide deck is already available on our website, and we expect that this recording of today's webinar will be available, in the next day or so. There are 2 additional webinars in this series. Their dates and their topics are indicated, on this slide. You can always go to the event section of our webpage for more information, on these webinars and other events. So today's webinar is on efficient, effective, and excellent, operations in hospital at home. This is really one of 2 sessions. Today's session will focus on, on some of the logistics and operations, and the next section will be led by our colleague Peter Reed from Unity Point in Iowa, and that one will focus on some of the operations issues related to specific services as listed on this slide: pharmacy, infusion, respiratory care, DME, diagnostics, all services, that are important in delivering hospital at home services. But today's session will focus on operations and logistics, and it will be led today, by Karen Titchener. And I have the honor of introducing Karen. Karen has been an important faculty member of the Hospital at Home Users Group. She, in many ways, is the Tom Brady of hospital at home care. She probably is wondering, where this reference came from. But Karen has had, the distinction of, I think, of perhaps having been associated with more hospital at home programs of anybody that I know of. She started and was involved in 5 hospital at home programs in the UK before being recruited to Huntsman Cancer Center and the University of Utah about 4 years ago to start its hospital at home program. Karen, has a deep experience in hospital at home and has been an international speaker on this topic. I have had the privilege, of looking at the slides today, and I think, today's presentation will be a real treat. So, Karen, please take it away.
Hi, thank you very much, Al. I'm going to talk today about the Huntsman at Home program, and which is a hospital at home program for oncology patients, but also really just talking about hospital at home and how do we do it, and how do we get going really with it. So this is an overview of what I'm going to talk about today. Who do you get as part of your leadership? What does the team look like? Do you employ the team yourself? Do you outsource it? What's your target population? I'll talk a little bit around staff induction and training, and then the logistics of the program. What hours do you cover? What's your shift pattern? What's your operational like? What's your clinical hub like? The day-to-day running, and the referral process for patients. So that's a quick overview of what I'm going to do. Talk about today. But before I start to talk about the operations, I just want to talk quickly about what hospital at home is and what it isn't. So for me, hospital at home isn't a hot chocolate and slipper service, i.e. it's not post-acute care, it's not home health, it's not case management. These programs are more laid back, slower pace, less intense. That's not really an insult. I don't mean it as an insult to these programs, but it's just they're not hospital at home. They're rock steady Eddie sort of programs where they just tick along, and it's mainly the same thing every day. So and also it's not about admission prevention, particularly within the CMS waiver, where admission avoidance isn't reimbursed for. So for me, hospital at home is a program that's on Red Bull and steroids, i.e. it's very fast paced, it's very intensive input. The interventions are quick and fast, and it's not for the faint-hearted. It's certainly for people that think on their feet. So the acuity and complexity of the patients, that's what differentiates hospital at home from any other community service. It also provides urgent access to diagnostics. It provides hospital level interventions such as intravenous fluids, therapy, and oxygen. It requires a multidisciplinary approach with multiple visits in a 24-hour period. We know with the CMS waiver that it needs at least 2 RN visits a day and a provider visit a day. So that's the minimum requirement for hospital at home patients. And it also requires that acute level specialist care. And in previous webinars, we talked about the inclusion and exclusion for these patients. But these programs are also very time limited. Some programs run up to 14 days. It tends to be much quicker turnover, maybe between 1 to 5 days. So leadership for this program. Winston Churchill said, continuous effort, not strength and intelligence, is the key to unlocking our potential. So again, leadership of this program, you may have multiple leaders, you may have one leader, but really you need somebody who's got a strategic head, somebody who's very clinical, and then somebody who's a day-to-day operations. All these characteristics that I talk about here, they may be intertwined, or not everybody will have all of these qualities. But for me, a leader in this program isn't somebody who's a rock steady Eddie. It's not somebody who's normal. They're normally a bit wacky, a bit out there, because they have to be very pioneering, and they have to have vision. They have to be an innovator, and really confident in what they're doing. Honest and have integrity, certainly accountable. And also somebody that can cope with the highs and lows, because not every day is a red letter day. There are days when you're trying to push a boulder up a hill, and there are other days when you get up to the top of the hill and everything looks great. Also, you have to have the ability to problem solve and be flexible, be able to delegate. And you're not necessarily the person that's going to dot all the I's and cross the T's. But something that I have always found really important for this role is that you find people who are early adapters, you find colleagues who are maybe in influential roles that that help you with the health system. So, you know, I've certainly had one person who's a tenured professor at the College of Nursing, Dr. Mooney, who has been my rock through all of this. She's always somebody that I can go to when, you know, and trying to move things forward. And also being part of the hospital at home users group, where you're talking to people who are doing the nitty gritty job every day. And it's good just to use people as a sounding board and help you move this forward. So for me, leadership is a big deal, and it will be the making of your program if you get the right person in. So the program and the patient capacity is a big issue for internationally, because like in the UK, programs are commissioned to say take so many patients, and often that is a big pressure, because like in the London program that I was involved in, you know, we had to see around 90 patients at any one time. However, if you've got patients that need multiple visits, then that's going to reduce your capacity. So for me, your patient acuity, your capacity of your caseload, and your staff numbers are all intertwined, really, because as I said, if you've got a patient that is much higher on the acuity score, then that's going to reduce your capacity. But in general, you know, I think on an 8-hour shift, any provider should be able to see 3 to 5 patients a day, and a 10-hour shift 4 to 6, and in a 12-hour shift 6 to 8. I've kind of talked to people around that, and I think that's reasonable. That certainly would be my expectation of a program that you're able to see these numbers. So with regards to staffing your program, you know, you need to be thinking about, who do you recruit? Who is it that you want in your team? Do you recruit some people and then subcontract with others? For example, our program, we're able to employ the nurse practitioner and the administrative support, but we have to outsource our home health because we haven't a license for home health. So and when you're recruiting these people, I've had success and failures from all walks of life. So, you know, you might think community is the best place to recruit, but actually a little bit like I said, if you recruit somebody from the community and they're used to a slower pace, the kind of hot chocolate and slippers thing, and they come into this program, it can freak them out. And it's just like, oh my goodness, there's far too many sick patients. And, you know, how am I going to see these all today? And then acute staff obviously have the acuity level, so they are aware of what these patients are like. But again, sometimes, you know, in one of my London programs, I thought I had recruited a great nurse practitioner because she worked in an emergency room. But when she went out to see these sick patients, because she didn't have her colleagues like 10 paces away, like the emergency room, she couldn't really cope with looking after such high acuity in the home. So, you know, as I've already said, it's not for the faint-hearted. It's not for everybody, because you need to be able to think on your feet. You need to be flexible, have good people skills, and be comfortable in your skin, be comfortable as an autonomous practitioner, because you are often on your own out there. So you really do need to, you need to make sure that you're recruiting the people with the right persona for this job. So with our program, because we're oncology, our induction is pretty bespoke for oncology patients. So, you know, we had lots of stuff around symptom management and things like that. But basically, we did a 2-week classroom where we had oncologists, intervention radiology, pain clinic, all of these people coming to talk to us. But a lot of it was around, some of our presentations were around the fundamentals of care with hospital at home, because again, for me, it's very, very different, because you have to have a different thinking cap on, you have to be a lateral thinker, you can't just look at what's in front of you, you have to think of the patient, you have to think of the family, you have to think, will they trip on that rug when they go to the restroom? Can they get to the restroom? What's food in their cupboard? All of these things. You just have to try and get your staff to think bigger than just what's presenting. If the patient's called you because they're in pain, think of other things that are associated with that and not just the presenting problem. And also, thinking around supporting the family and the caregivers. Because if this patient's not in the hospital, the burden of care then goes on to the family. So how can you support them and be available for them? And then after we've done the classroom work, then obviously there's things like the mandatory training, the medical record, IT. All of our staff do the CAPC training program. And we also do competencies, so around PIC lines. What we really want to do is to make sure that the level of care that would be given in hospital is the level of care that they're given at home. So that's same standard. So for example, the home health that we work with, all of their staff that are seeing the Huntsman patients have to go through this program too, so that we make sure that the level of care that these patients are getting is the level that the university would be expecting. And another big thing that we do for our staff is where they shadow different people. In fact, because we take high-PEC patients, they even go and watch a high-PEC operation. So they've got, it's probably about a 6-week induction program altogether, but that measures the complexity of these oncology patients that we are looking after within our program. So, you need to be as effective and as efficient as possible. So what does that mean, and what do you put in place in order for that to happen? You want to have a smooth operational day. These patients are very sick. They need you to be very responsive. When your staff are out in the field, they need you to respond to them if they need help. So you have to kind of have this machine that's working all the time to keep the patient and the staff and the systems all flowing together. So for me, on your day-to-day operations, you need to have your lead provider. You need to have providers out there doing the work, going out and seeing the patients. We definitely need to have the RNs, the nursing aides, also physical therapy, occupational therapy. All of those are provided by our home health. You then need administrative staff to answer the phone, to take referrals, to schedule appointments. And in all of the programs I've set up, we've always had a clinical hub. So there's, if you see Thomas the Tank Engine, they're like the fat controller. They're organizing everything. They're taking information from the field. They're talking to the acute hospitals. They're guiding the staff as to what to do. So it's really important to me to have a clinical hub, and then to have just a day-to-day manager managing logistics for the day, making sure the phones work and all of those kind of things. Now we decided to go with supplying cars, so we have 4 cars in the field, all of which have got the equipment that the staff need: EKG, bladder scan, IV access. All our providers also have a first dose pharmacy bag. I know pharmacy is being talked about next week, so I won't go too much into this, but basically they all carry this bag that they can give antiemetics or IV fluids and things like that. So because a delay in treatment could mean that the patient has to come back into hospital. So for me, having that first, dose bag where you don't have to write an order and then wait for it to be delivered is really, really important to, again, being as effective and as efficient as possible. And also, if a patient has a need, they have a need now. They don't want to be waiting hours to get their medication in order to address them. Something that you need to bear in mind is with all the best will in the world, you may design a program and within days you're having to think, oh yeah, that doesn't work. How do we do that better? So your program will evolve around the patient, around your health system. So, don't write anything, in stone. It will evolve and it will be flexible. And don't be afraid of change, because change is good. It means that you've learned by something that's not working, and then you're adapting it and moving it forward. So the communication system. So I just want to talk about how that works during the day. So as I've already said, you need somebody answering the phones, taking referrals and scheduling appointments. For me, in all of my programs, the worst thing that could happen is that somebody's trying to get hold of the team and they can't get through, whether that is a patient, a desperate relative, or the patient's acute provider. So for me, the phone always has to be answered. So how do you set up a system where the phone can always be answered? Now, we looked at using the hospital system, but the people answering it wouldn't have known what to do. So now what we do is we set up with Verizon a hunt group, so that if somebody phones in, of course, it first of all goes to the admin office, but if she's on the phone, then it will hunt around whoever's on that day, and all of the team, either out in the field or in the clinical hub, will then answer that phone. So that's kind of just one of the systems that we've set up. You may know of other systems. I'm just giving you a little bit of what we've done. We did the same in our London program, where we had about 20 lines, so the phone was always answered by somebody. With the clinical staff have phones, computers, hotspots. They can get into Epic on their PC in the patient's house. We've worked with billing around the documentation in order so that they code it correctly for payment. Although, of course, with the waiver, that's on a DRG, so that's a little bit different. Our partners at the minute have read only of Epic, but with the waiver, we're in the process, if not already, moving them to actually getting into being able to use Epic. And that is to do with orders, particularly for labs and things being done, and printing labels, and the complexity of things like that can get a little bit overwhelming. So this is just, how do you make it as smooth and effective as possible? The clinical lead in the hub, really, they are there to accept phone calls and to delegate and to orchestrate, care, to guide care, to write orders, to take feedback, to talk to the oncologist if one of the nurses, out in the field is worried about a patient, that they can phone into the clinical hub. The clinical hub can reach out to the patient's oncologist, and we can sort it that way. So we're a 7-day-a-week program, 8 in the morning to 8 in the evening, and then at 8 o'clock, our home health partners take over the phone, and a duty RN will then be on to speak with the patient and do any visits, and if they need so, they have follow-up from the inpatient hospitalists or from the medical director of the home health. Each morning we have a virtual ward round where the field staff all call in and get a report and get care guidance for each of those patients, so that everybody knows who they're visiting, what the expectation is on that visit, and then during the day, our home health partners use a HIPAA compliant app called Matters Most, And that's where all the conversations of the day go. So for example, with all our first visits, we try and do a joint visit so that the patient's not overwhelmed by multiple first visits. So our provider and RN will often do a first joint visit. That helps with patient safety too, because obviously you don't know what you're walking into. So if you're going in as a pair, then on a joint visit, then that really helps with staff safety as well. But so with the matters most, somebody that you can text and say, I'll be there in 10 minutes, or they can say, Mrs. Jones needs some medication, and all of those things can go on this app, and that's the daily chat box that is the busiest really for the field staff that are out on the day. Referrals can come through on Epic, and then the lead will have a discussion with the referrer, and then they will go and visit the patient. So as I say, the clinical lead orchestrates all communication between patient, staff, oncologists, case managers, the clinics. They review, they go on to Epic and see, right, who's been admitted today, who could we take out potentially onto the CMS Waiver program. They attend the discharge meeting, but they have already know the patients that they might have potential when they're on there. That while they're doing all of this, they're constantly getting feedback from the field staff. And after staff have visited a patient, they will then call in and give a report, so that this clinical person really knows everything about everybody and what's going on. And they also liaise a lot with the patient and the carers as part of this program. So this is our referral process for our whole program, but for the CMS waiver, where you're taking patients from an inpatient or the emergency room, it's a little bit like what I've said. Somebody identifies that the patient would be suitable, they meet the criteria, they consent the patient, they phone, we accept the patient. Our clinical coordinator will go and see that patient on the ward, make sure that the discharge is well done, and then we will see the patient within 2 hours of discharge. So the operational referral pathway is, the referrer is received in the clinical hub, and then the administration will take all the patient's details and demographics, and they will put them on the system. And then the clinician will gain more information from the referrer, make a decision. Should we take this patient? Should we not? Then they will review the patient on the ward. And when that patient is discharged, we will review the patient within 2 hours. The visiting providers feed back to the clinical hub during the day, as I've already said, and also part of the multidisciplinary team all feed back into that clinical hub so that we know what's going on with each patient. The patients will receive at least 2 RN visits a day and a nurse practitioner visit for 5 to 7 days. So key points to remember is you certainly need strong leadership. The SAS in the UK say recruit the best to be the best. And so I think, if you try and recruit, don't settle for second best. Try and recruit people who you really feel that their ethos matches the ethos of hospital at home. Have a good in-depth training with good philosophy of care. Daily operations need to be fast, responsive, and effective. You've got to respond to the patient's needs. You've got to respond to the referrers, and you need to know what your capacity is. And each day, look at your capacity management and think, how many patients are high acuity, how many patients just need the basic. So you really need to know that as you start your day, so that you know how many referrals you can accept or how many visits you need to know. And seamless patient flow, really, from the acute to the community. The patient shouldn't have any bumps or lumps. They should just be able to have a smooth transition of care. and good communication with the team, with the staff, with the patient's family, with the oncologist. Communication is the main thing. Ensure good patient and family support, and don't be afraid of change. And my philosophy is always think big and stay strong, and you will make it. Thank you.
Thank you, Karen, for that great presentation. We've had a number of questions chatted in. Let me just start out with a very, very specific question, and then we'll go to some, broader discussion questions. There was and I had this question as well. In your communications slide, you made reference to partners, and it was unclear to some members of the audience as well as me about what you meant by partners here. This was in the line where you were talking about read-only Epic, et cetera.
Yes, so that's our community home health partner. So because the University of Utah doesn't have a home health license, we have to outsource our care. We can have the nurse practitioners and the admin and the operational staff, but a lot of the visits we can't employ RN to do home health visits. So that's why we partner with a home health. Does that explain?
Yes, that explains it for me, and I think that is very helpful. So let me take up some of the questions Q&A in no particular order. A couple of the questions related back to your slide about what home is not. There were questions about it not being home. There are questions about it not being skilled nursing facility care, for example. So let's focus first on the home health question. One of the early questions about home health asked about the use of home health agencies, even if this was not home health, and how you used it. You alluded to this in your answer about partners, but they asked, the question I think really referred to, is a Medicare episode, for example, billed? Or
No.
is the home health doing the equivalent of a Medicare, episode of care?
Yeah. So before the CMS waiver, when our program was operational, these patients could be on the home health oasis and then they could be billed. Obviously, clearly with CMS, you can't double dip, so you can't, they can't claim for these visits when these are inpatient, when these patients are being treated as an inpatient. So we then have to, as an organization, we have set up a memorandum of understanding with the home health that if they're doing these visits, we give them per visit. So if an RN visit, I think it's around $135. Don't quote me on that, but I think that's what it is. So with the CMS waiver, if we're asking our home health partners, they cannot put it on Oasis because it's the CMS waiver, but we will then reimburse them for the visits that they do. And obviously then if our nurse practitioners do the visits again, that they wouldn't be claiming for that visit under the normal fee for service because it's all embraced in the DRG reimbursement for that inpatient. Does that explain that?
Yes, and I think it's very important to point out that in the context of the CMS waiver, there's a payment to the hospital for the episode of care, and that's that right. The payment for these home health nursing visits, if you will, really needs to come out of that original payment.
That's right.
And that a separate Medicare home health episode cannot be billed.
That's correct.
Yeah. Staying with the theme of what this is not, one of the questions related to skilled nursing facility at home, and how hospital at home might differ from the patients that might need SNF at home in that particular model.
Yeah, I mean, it's, I think SNFs are different here. Certainly in the UK with COVID, they are going into care homes now with the hospital at home. But here, you know, I think that would be very difficult because again, it's around funding. Are you paying for the sniff? It's different if you're transferring a patient who should be an inpatient to their own home, then you know, we're not paying for that home. But if they're going into a sniff, then who's going to pay for the sniff? It's something that we certainly have never gone into sniffs with our hospital at home program, and with the CMS waiver, it's probably above and beyond me to say whether this can be done under this waiver, because again, it would be up to the hospital to pay the sniff for that bed if that's what's required for that patient.
Right. So if I could just elaborate a little bit on that answer, we at Mount Sinai have had some experience with the model of sniff at home, or if you will, what we call rehab at home. And we can post some of the papers on the website, you know, for the person who asked this question about that particular model. Also, in our mind, you know, that is a distinct service from the hospital at home, and that, yes, you could build it off the same platform of staff, but it is a fairly distinct service with its very distinct characteristics in terms of how long a patient would stay, what type of patient, you know, would go into it, and the referral processes that would be involved. Post a link on the website to some of the work that we've done in terms of rehab at home in response to that question.
That's really helpful.
Karen?
Yeah.
One of the questions related to rural programs where resources might not be nearby. And if you had, you know, some comments on how logistics and operations might, you know, need to be adapted for more rural programs.
Yes, well, actually, we're in the process of implementing our rural program to 3 rural counties. And in doing that, we are looking to work with the local, you know, community hospitals for looking at those patients. So if they go to the emergency room in these local clinics and they're a Huntsman patient, can we then take them from that emergency room back out rather than them being admitted? But equally, that we would partner with those hospitals that if we felt a patient needed some step up care, so they deteriorate acutely, well, rather than them doing a 5-hour round trip to the Huntsman or a 10-hour round trip to the Huntsman, we may be able to step them up into the local hospital for that sort of 24-hour review and then take them back out. So I think with the rural communities, I think it's still very doable. I think you just have to get your logistics right. I've been talking to, for example, the paramedics down in Moab, and they are a non-for-profit, and they've said that they would partner with us, and if we felt somebody needed urgent IV fluids or urgent medication, that they would go out and do that for us. You know, so again, it's just about looking at your partners and thinking, you know, you can't think within a box for any of this. You always have to think outside the box, and you always have to think, well, how do we do that? And my philosophy always is never say no, say how. So it's, well, how do we work that out? If you're asking me to do that, I don't want to say no. I want to say, well, how would that work? And how could we do that? So in the rural community, I think it's very, very doable if you've got the right partners lined up.
Right. And I think, you know, that in answer to this question, I think we also have to recognize that there is a continuum of geography, you know, in which hospital at home has been used. You know, there are rural communities, and there's the question about rural communities, but also, you know, less urban areas, you know, where still distance is an issue.
It is.
Notice, you know, that in your implementation, you use cars, you know, for some equipment, whereas in New York City, where we do hospital at home, we would never think of using cars because it would just take longer, to actually do anything, if we actually had things coming in cars and parking them. So let me go to some of the other questions. There was a question, Karen, about your thoughts about ratios of MDs to patients, NPs, RNs, and admin. You put up some numbers in terms of number of visits per day, et cetera. I don't know if you could comment a little bit on staffing ratios based upon your experience.
Yeah, well, my background is a nurse practitioner, and actually all 5 programs that I have set up have been nurse practitioner led programs. So we partnered with MDs, but the nurse practitioners led the program. So in our program, with the Huntsman program, we have a medical director who is also the medical director of the home health. So and has the amazing ability. I don't know how she spins all the plates she does, but so she is the overall medical director. She will speak to the team. She's there for the team all of the time, but the visits are all done by nurse practitioners. So and so for our program, we have 9 nurse practitioners. One of those will always sit in the clinical hub, and then they do 3 12-hour shifts a week, and then 1 week they do 4 12 hours to make up the hours. So that's kind of how we do it. So we're more heavily weighted, as was my London program, more heavily weighted on nurse practitioners than MDs. The MDs are there, but the nurse practitioners are the workhorses, if you like. They go out and do the visits and things like that. And obviously we have the interface, because we're part of the acute system. We always have the backup of the acute physicians when we need it for the patients. Does that answer that? I mean, with regards to the RNs, we have the home health that we partner with. They dedicated 8 RNs fully for our program. So at any one day, there are we have probably 3 nurse practitioners, 3 RNs on that are visiting the patients.
Thank you. I'm going to pair up, 2 questions that have come in related, I think, more to particularly to oncology patients. There was a recent question, chatted in, about specific diagnoses for oncology patients and whether there are specific diagnoses or types of oncology patients enrolled in your program. And the partner question that came in earlier was about the issue of pain management and how you manage that or deal with that in hospital at home.
Yes. So with regards to diagnosis, obviously, we do take any cancer diagnosis as long as the patient has active cancer and they're being seen by the Huntsman Cancer Institute. We will see the patient. I think it's more to do with maybe what DRGs might we see. A lot of the patients that we see are to do with symptom management. So either their pain is badly managed, they've just had their chemotherapy and they've got nausea, vomiting, and the failure to thrive. All of those kind of things are the kind of patients that we would tend to see, if that helps. But they're mainly medical oncology patients that we see, although we do see some BMT patients, but most of our referrals would come from medical oncology, and often the patient has metastatic disease, so they're complicated, and they may have lung cancer and COPD, or they may have they may have heart failure as well as their cancer diagnosis. So they're complicated patients to look after. What was the question about the partner?
It was about pain management.
Oh, pain management. Yeah. So with regards to pain management, we obviously we're part of the acute trust. So if we felt the patient was in pain crises, we can get them an appointment at the pain clinic. They might get a pain pump. put on, but we do manage acute pain in the home as well. You know, whether that is that we obviously our one thing that our first dose kit doesn't have is opiates, because it's America and everybody freaks out about opiates. In our London program, it was a bit different. You know, I say to people, you know, in our London program, we could have left a patient's door open. There could have been 20 vials of Damorph in the house, and nobody, not the worst down out in the world, would have touched it. But I know it's very, very different here. So, you know, we have rules and regulations that we have to comply with. So, you know, our staff don't carry opiates around, but if the patient needs it, again, our partners have their own pharmacy. So if we need something urgently, we can get things delivered within 2 hours for those patients. So we will manage acute pain at home. If we don't feel that we're going to manage it well, we can get the patient seen urgently at clinic, at the pain clinic, because we've got a SOS, you know, we've got a supportive oncology team that is very good at looking after these patients.
Karen, I know that in the context of the Medicare waiver, because we're operating under the aegis of the hospital, there have been a number of questions that have been raised about self-administration of medications, as well as, you know, as other related issues, you know, in terms of controlled substances. I was wondering if you could, you know, just comment a little bit on your experience, you know, with that.
Well, I think with regards to that, there's probably more experts on this than me, but you know, I think when the patients are in the waiver, we have to administer the acute medication. It's very important, not only for the complexity of it, but also so that you're monitoring the effects of it. So if a patient is self-administering, how do you know if their pain's getting better, or if their nausea is getting better? So you know, I think part of the waiver is that as they would get in hospital, you would have to administer the acute medication that you have been prescribing for them.
Right. So I know that many of the programs that have gotten waivers have wrestled with the question of controlled substances and self-administration, and there are probably, you know, different approaches that all of them have taken, and this is probably, you know, something, you know, that we'll try to address in terms of the Q&As that we post on the website.
Yeah, I think it's a big issue, and you know, I think everybody just wants to get it right and to do it right.
Right. There was a question about the role of telemedicine.
Mm-hmm.
How do you use it?
Telemedicine, we would certainly use telemedicine with our patients as a follow-up, as a checkup. So it is something that we do. And it's certainly, as we expand to rural, we will use it more and more. Thankfully, the great thing, the one thing that COVID has done is that it's got our providers better at doing telemedicine. Because when COVID first started, you know, our cancer patients didn't even want visited. So we did a lot of telehealth and telemedicine then. And I think it's definitely a way that you can see more patients and you can touch base with more patients. So for me, it has to be part of what you do. It has to be part of your infrastructure that you use telemedicine on a daily basis for your patients. So not only are you visiting them, but then, you know, if you visit them in the morning and maybe you've started a new medication, it's nice to, I always feel as a clinician that you can't beat eyeballing a patient, you can't beat looking at them. So, you know, just to pick up the phone and talk to them, it's much nicer if you can see their expression. Do they look like they're still in pain? Do they look like they, they still feel very weak. So I think telemedicine is far, far better than just picking up the phone and calling somebody. So it definitely has to be part of what you do, part of your infrastructure.
And the role of telemedicine is likely to evolve. I mean, you know, in the time that we've been doing hospital at home, you know, certainly, you know, every quarter, you know, I think that we're using telemedicine slightly differently than we did, you know, the previous quarter. And certainly, you know, for many of these programs, and my guess is, you know, for the programs that you did in the UK many years ago, telemedicine was a telephone call.
Yes.
Right. We have time for just a few more questions. There's a question about how do you provide meals in the program?
There aren't that many people that, in fact, next week, I think they're going to talk about that at the next session. For us, we have got the home health is going to be helping us with that. That part of it. I haven't got the details of what we're doing on that, but yeah, I can't really answer that because I don't know what we're doing with that just now. Sorry about that.
Well, I think, you know, that, you know, certainly our program and many programs are attuned to the issues of food insecurity and understanding, you know, whether there is access to food. And certainly in our program, we've made a commitment, you know, that if food is an issue, that we will make arrangements, you know, to have food delivered, you know, for those patients who need it. For some patients, it's a boon to be home and being able to, you know, have their own food, you know, in case, you know, there's no issue, we certainly would not intervene.
Yeah, that's right. Yeah, I mean, I think if patients are going home and they've got family and there's a good infrastructure around them, I don't think food is a problem. But if you're sending somebody home and they're going to be on their own and they can hardly fend for themselves, then you've got to take responsibility as to what you do for them. In our UK program, when we would have provided aides that would cook meals for people and, you know, go shopping for them and bring food into the home and things like that. But with this, you know, I think we have to really look and see if the patient lives on their own, how are we going to provide that? And I know that we're working with the home health on how we're going to do that.
Well, Karen, I want to thank you, you know, for a great presentation, you know, and a great Q&A. You know, this was, I learned something. I've been doing this for a while. When you were talking about the Hunt group, you know, that was something, you know, that I learned, you know, for our program, and then we're going to have to look into that, you know, as well, in terms of, you know, how that might help with some of the problems, you know, that we were actually discussing even today. So as the hour is almost up, you know, let me remind everybody, you know, on this slide, you know, about the link to our website, where we also, you know, provide a number of tools and where we've been developing our TA capabilities. You know, you will see this on our website. It is powered, you know, by CAPC right now, by our colleagues at the Center to Advance Palliative Care, that helped us, you know, rapidly put this up. In addition, on our website, you will find a new resource that we just put up, I think today, you know, and that is an annotated process through the CMS waiver application for those who have not completed that process yet. This is just a reminder, you know, where we stand right now. We just finished our 5th webinar, and the slide deck is posted on the website, and the recording will be up hopefully by tomorrow. And please join us, you know, on the 16th, you know, for part 2 of this, in which we're going to be discussing specific home ancillary services, and we'll be closing out at least this initial webinar series on December 23rd, talking about evaluation of home quality and safety. For updates on upcoming events, please go to our website and the events tab, you know, at hausersgroup.org. Thank you. It's been great spending the hour with you, Karen, and hearing your presentation on the operations of delivering hospital at home. Please join us next time, as Peter rejoins us from Unity Point to discuss part 2 of this webinar. Thank you all.